Kim. I'm going to be here discussing stroke with you. I currently work in the neuro ICU. I've been a neuro ICU nurse for 7 years now. And that just went off. Is that recording?
This one is, yeah.
Okay.
You're just really dark on it.
Because the GoPro isn't recorded now. So my objectives for this presentation are to differentiate between the two different types of stroke, ischemic and hemorrhagic, describe stroke prevention strategies, review the importance of decreasing door to CAT scan time, identify the barriers that can interfere with door to treatment time, discuss the nurse's responsibility when caring for a stroke patient, and list the steps taken to perform a dysphagia screening. So stroke. According to the National Stroke Association, a stroke occurs every 40 seconds. It is the 5th leading cause of death in the United States and is the #1 cause of disability. Sometimes referred to as the 4Ds: disability, disparity, death, and dollars. According to the CDC, about $34 billion a year are spent on stroke patients in regards to rehabilitation, medication, and missed days at work. So causes and risk factors. There are two types, modifiable and non-modifiable. So first I'm going to discuss modifiable. Alcohol consumption, obesity, smoking, poor diet, drug abuse, and hypertension. The next one is non-modifiable. Family history, age, gender, and race. African Americans are twice as likely to have a stroke over Caucasians. African Americans have the highest rate of death due to stroke, according to the CDC. In regards to gender, stroke kills twice as many women than breast cancer, which I kind of found surprising. Stroke is the 3rd leading cause of death in women and is the 5th leading cause of death in men. When educating your patients, you can teach them about the ABCs. So A, aspirin helps decrease blood clot formation. According to the CDC, about 9 million people are not taking aspirin as recommended. Blood pressure control. There's about 40 million Americans who have uncontrolled blood pressure. And cholesterol management, either dieting and or taking a statin. And smoking cessation. 54 million adults smoke. Ischemic stroke. This is the most common. About 80% of all strokes are ischemic. Occurs when a blood vessel is blocked by a clot. It can either be embolic or thrombotic. Embolic is a blood clot or plaque that blocks the blood flow. It's typically caused by atrial fibrillation. And thrombotic is caused by a clot that forms inside one of the arteries supplying blood flow to the brain. It's typically caused by high cholesterol or atherosclerosis. 2 different kinds of treatments, which I'll get more into, but the first one is TPA, which is tissue plasminogen activator, must be given within 4.5 hours of onset, and then mechanical thrombectomy, which is the actual clot removal. The only candidates for this are patients with large vessel occlusion, and it must be done within 6 to 24 hours of onset. So I'll bring this a little bit closer. So here, the red arrows indicate the large vessel occlusions. So some of the large vessels or the candidates for the mechanical thrombectomy would be the middle cerebral artery, the anterior cerebral artery, the posterior cerebral artery, and the basilar artery. So ischemic stroke. Symptoms are, keyword is being sudden numbness or weakness of the face, arm, or leg, especially on one side of the body. Sudden confusion, trouble speaking or understanding. Sudden trouble seeing in one or both eyes. Sudden trouble walking, dizziness, loss of balance or coordination. And sudden and severe headache with no known cause. So this right here is a picture of an ischemic stroke. Over here, you can see the clot. Then you see this gray area over here. That's known as the penumbrum. The penumbrum is the area surrounding an ischemic event. It's still viable tissue, so that's what we're kind of going for with rapid treatment or earlier treatment and realization of this stroke, is just to prevent expansion of the penumbra. And over here is a CAT scan of an ischemic stroke. So this darker area over here is the dead tissue. So TPA, everybody familiar with that or no? Has anybody heard of it?
I've heard of it.
Yeah, okay. Most people are pretty unfamiliar with it, and if you have to give it, your hands are going to be sweaty, you're probably going to be dropping things, and it's going to be everybody running around screaming because it's kind of like a big deal. It is the medication, also known as the clot buster. It converts plasminogen to plasmin, which degrades the fibrin matrix of the clot. So the criteria for receiving TPA is you need to know the onset. So most of the time you will get patients who present to the ER and they're like, well, I went to bed because I had a headache. Or, I felt a little weak and I went to bed and then I woke up and the symptoms were still there. So does that meet the criteria for less than 4.5 hours? No. If a patient wakes up with symptoms, they're not going to meet the criteria because we don't know if it happened an hour before they woke up or 9 o'clock last night when they went to bed. Negative head CT. So you're going to get a CAT scan, and that's basically just to rule out that there's any bleeding in the brain. Like I said before, the onset of symptoms is less than 4.5 hours. Their INR is less than 1.7. So patients may be on blood thinners such as Coumadin for AFib. You can still give TPA. You just need to check their lab values, and if their INR is less than 1.7, you can go ahead and give it. You just don't want to give it if their blood is too thin. And a normal glucose and platelet levels. The exclusions to receive TPA are serious head trauma within the past 3 months, bleeding from the stomach within the last 3 weeks, any type of bleeding disorders, use of blood thinners, pregnancy, and positive head CT. And positive head CT is just in regards to there being blood in the brain. So the dosage for TPA, it's different in regards to how it's prepared. It is different at different institutions. Here at Virtua, the nurse will prepare it at the bedside. It comes in a little vial. You have to reconstitute it. At my institution, pharmacy will send it up already pre-made, so we don't have to worry about that. So you just have to follow the policy for the hospital that you're working at. But the dosage is standard throughout the United States. It's 0.9 milligrams per kilogram with a bolus of 10% given over 1 minute, and then the rest of the infusion is to be given over an hour. Requires a double nurse check prior to administration, so it is one of those high-level drugs, high-alert medications. Some adverse reactions are obviously bleeding. You'll get bleeding. It could be if you tried to get an IV over here, or if they have a skin tear, they'll start bleeding. It could also cause intracranial bleed and a retroperitoneal bleed, which is bleeding into the abdomen. Anaphylaxis or angioedema. So during the first 24 hours after TPA is given, you're going to avoid any type of invasive procedures, so no IV insertion, no IM or sub-Q injections, no antiplatelet medications. You're also going to keep the patient NPO for the first 24 hours, so nothing by mouth. Hemorrhagic stroke. Unfortunately, this is the one that I see most often because these are typically more severe and have more complications. Is either caused by a brain aneurysm or a weakened blood vessel that bursts. Accounts for 15% of all strokes. Intercerebral hemorrhage is the most common, which is caused by high blood pressure. Subarachnoid hemorrhage is typically caused by an arterial venous malformation or AVM or a ruptured aneurysm. Treatment is either symptom management, typically for hypertension. They'll just monitor blood pressure and continue to just do neurological checks frequently. And then the last one is surgical intervention. So symptoms for a hemorrhagic stroke, most of the time the note will say WHOMS L. So worst headache of my life. That is typical classic hemorrhagic stroke. People will sometimes complain of like almost like a thunderclap kind of headache. Nausea, vomiting. They'll present with very high blood pressure, so 200s, 220s. They may also present with seizures. So this is a picture on the left of a hemorrhagic stroke. This is a picture of a CAT scan. So yesterday, I admitted this patient. So that's his CAT scan right there. That is all blood right there. He has a very poor prognosis. It is on the left side of his head, so it's going to affect his language. So he's going to have a hard time communicating, understanding, and he's also right-handed, so it's going to affect his right side. He was a practicing physician, and so it was a rough day yesterday. But this is typically what I see. He was not a surgical candidate because he had received antiplatelet medication. He actually came in for an elective cardiac cath. Woke up the next morning, they found him on the floor. They took him to CAT scan, and that's what they found. Surgery, did not feel comfortable doing the surgery because of the antiplatelet and because of how deep and involved this is. So this patient will most likely be transitioned to comfort care over the weekend. No, he's currently intubated, so he's on a breathing machine. Not very responsive, really only moving his left side. Yeah. Then there's TIA, which is transient ischemic attack, which is just kind of like an ischemic stroke. It presents like an ischemic stroke, but the symptoms only last for about 24 hours. Can be a warning sign that a stroke may happen in the future. 40% of people who have a TIA will have an actual stroke, according to the National Stroke Association. So prevention of stroke, they should get worked up. They should have an echocardiogram, blood work, mainly checking for cholesterol levels, blood pressure management, healthy lifestyle, so you want to get them to quit smoking, get outside, eat healthier, work out. So differential diagnosis. So this is something that you should keep in the back of your head when admitting a stroke patient. One of the first things that you're going to do if you have a stroke patient is to check their blood sugar, because all their symptoms might be resolved if you just push a little D50, give them some orange juice. So hypoglycemia will present with confusion, lethargy, unsteady gait, and slurred speech. Alcohol withdrawal, headaches, tremors, seizures. Seizures can actually present, I don't know if you guys are aware of this, they can, when everybody hears seizures, they think of like the general tonic-clonic, the shaking, but it can be as simple as staring off into space for a few seconds and not responding. So people can sometimes get that confused with an ischemic stroke, thinking that they have that gaze preference, but normally the staring spells don't last that long. Temporary paralysis, jerking movement, and then brain tumor can present with symptoms of confusion, difficulty walking, difficulty with speech, and blurred vision. So diagnosing. So National Institute of Health Stroke Scale, it's the gold standard for pretty much, I don't want to say diagnosing, but it's done in all hospitals, so whether it translates between hospitals. So if you're transferring a patient, or if a patient had a previous stroke, you can always look up these numbers. So I'm going to go through and discuss that. I was going to pull it up, but I won't. So I have it in front of you. It's 11 categories. 0 means normal function. The range of numbers, so the total, if your patient has a total score of 1 to 4, that will indicate a minor stroke. 5 to 15 will indicate a moderate stroke, and 21 to 42 will indicate a moderate or severe stroke. So going through this, level of consciousness. So right now we're all zeros. Hopefully we've all had our coffee. So 0 means ear alert. You walk into the room, patient opens their eyes, kind of acknowledges you. Not alert, it might be in the middle of the night. You might have to kind of arouse them, but they kind of pop right up. Not alert, so you're really going in there, you're pinching them, you're sternal rubbing them. They're really not responsive at all. They will kind of move their extremities to painful stimuli, but they're not very arousable. And then 3 responds only to reflex. So that kind of means you pinch them, they might kind of pull in or turn out. You pinch their legs and they kind of bend them up, but it's not very purposeful. It's just considered a reflex. Level of consciousness questions. So this you're going to ask them. It really doesn't have to be month and age. It could, where are you right now? You can make it, tailor it to your patient. As long as you ask 2 questions and make sure they're right, you're going to grade them off of whether they got it correct, incorrect, both questions correct, both questions incorrect. Then you're going to ask for commands. So you're going to have them perform these 2 commands: squeeze hands, let go, raise the roof, wiggle your toes, whatever you want them to do. If you have them squeeze your hands, also have them let go, because sometimes I find this very often. You put your hand in their hand and they'll just squeeze, but they're not doing it on purpose. They're not doing it to your command. They're just kind of holding on to your hand. But if you ask them to let go, then to me that's following a command. Best gaze. So this is checking for cranial nerve 6. So this, you're going to put your fingers in front of their face and you're going to have them follow your fingers. You're just going to go horizontal. You're going to look for normal gaze, so that's following. Partial gaze paralysis gaze is abnormal in one or both eyes, but forced deviation or total gaze paresis is not present. So sometimes the doctor will actually hold their head and turn it, and so if they're able to kind of turn and follow with it, then you can give them credit for it, but if it's forced, then I would give them a 2. That's also known as doll's eye, which they do during the brain death exam. They'll do doll's eye. So they'll hold your head like this, and you got to think of a doll. So a doll's eyes don't move unless it's like one of the new ones. Then it doesn't. Then you can't. Yeah. So it kind of gets aggressive when they do it, and I know I'm off topic, but they'll hold their head and they'll flick it over on both sides. And so what you want is the eyes to actually like move over towards it. Or no, stay midline. You want it to stay midline, because if it's doll's eyes, they're gonna go with it. They're gonna track. But yeah. Yeah. So the next one is visual. So this one, so I'll bring this closer. No vision loss. You're gonna test. You're gonna have them put. You can either put your hand over their eye or have them put their hand over their eye, and you're just gonna hold up fingers to one, ask them if they see it. You're gonna switch. So this is what you're checking for, and this is what they're gonna see. I've done this for 7 years now, and I don't know all these terms, and they're all anopia or whatever. So this is their eye right here, and they're not gonna have any peripheral vision. All they're going to see is straight ahead. But these are the other eye complications, but we're not going to go into that because that's not what we're talking about right now. Next is face. So this is where you're going to ask them to either smile. It sounds very weird because you're going into them, they just had a stroke, and you're like, can you smile for me? And they're like, why am I smiling? So you get them to show your teeth, if they have any teeth. You're going to look for the wrinkle here. So you're going to see if this is flat, that's going to be considered 1 point. 2, you're going to give it if they have total or near paralysis over just the lower. And then complete paralysis is where if you ask them to raise their eyebrows up or kind of squint down, you don't see the wrinkles as equal on both sides. Next is motor. So this is going to check for a drift. So you're going to ask them, you'll hear this all the time, and I hate using this, but I do it. You're going to ask them to hold their arms up like they're holding a pizza box. Because does anybody carry their pizza like this? No. But that's how we do it. And you're going to have them close their eyes, or you're going to cover their eyes. They're going to hold their hands up for 10 seconds, and you're going to look for that downward, inward drift. So that's considered a pronator drift. So if they have that drift on either one of their extremities or upper arms, you're going to give them a point for that. It's also going to test for their strength too. So no drift, they're holding it up. Drift, downward in. Some effort against gravity, so if they're able to kind of lift it up but not hold it up for that full 10 seconds, no effort at all. So if you have to lift their arm up and they drop it right back down, no effort obviously, and then 4 is no movement. So motor leg, you're going to check one leg at a time. We're not looking for them to be like a yoga instructor during any of this. So they're going to be laying in the bed, lift their leg straight up, hold it for 5 seconds. If you see any type of drift down, they're going to get a point. If they can't lift it off the bed, if they can't press against your arm at all, you're going to give them points for that. Next, limb ataxia. So this one you're looking for, you're going to stand in front of them, you're going to hold your finger in front of their face, and you're going to move it, and you're going to have them touch and touch and touch and touch, and on both sides. And you're going to check for that. If they're not able to touch your finger or go back to their nose in one limb, you're going to give them 1. If it happens in both limbs, you're going to give them 2. So sensory, this you're going to check either with, this is just a test to see if they can feel. So I wouldn't use anything sharp. We're not doing acupuncture. So just maybe like a blunt needle or like a Q-tip or something like that. Most of the time you can use the Q-tip. There's like the hard end on the one side and then the Q-tip on the top. You can tell the difference between the dull and the soft. You're going to do it on all extremities. See if there's any difference between all 4. Best language. So you're going to talk to them. You're going to see if they have any aphasia. So aphasia, I won't go into too much detail, but there are 2 different types of aphasia. Expressive, meaning you can't get your words out. You can't express yourself. Receptive, meaning I'm asking you to do something and you're like, well, the sky's green. You're not, following my commands. And then there's global, which none of us want, but that is both expressive and receptive. Dysarthria. So you're going to see if the patient has any slurred speech. So you're just going to kind of grade them off the severity of that. If they have a breathing tube in, you're unfortunately not going to be able to assess that. And then the last one, this is the kind of test to see if the patient has any type of neglect. So they don't know that they have a left side. You can hold their arm up in front of their face and you're like, whose hand is that? And they're like, it's yours, get it out of my face. But you're like, no, it's yours. So you have to see if they're able to fully assess and differentiate between your limb and theirs. We actually had a patient who came in and the only reason she was admitted and the only reason why they knew she had a stroke was because she went to church and she only had clothing on the one side. She didn't put her arm in the other side.
Oh man.
She only put makeup on the left side, or like the one side of her face. So when she got to church, they were like, well, that's not right. So then they took her to the hospital. But she was not a TPA candidate because we don't know what time those symptoms occur. Another diagnosing tool, the Cincinnati Pre-Hospital Stroke Scale. So this is what they use pre-hospital. EMS, paramedics will do. It's called FAST. I'm sure, I don't know if you guys have seen this poster, but it's like everywhere. So face, you're gonna look for facial drooping, have them smile, show their teeth. Arm, You're going to look for that drift again. You're going to see if there's any type of weakness on either side. If there's family present, and you should be doing this as well at the bedside as the nurse, you want to get a baseline. So ask the family, well, are they normally strong in all four limbs, or is there one, do they have that, limp on the right side? Just because you don't want to be saying, well, they're weaker on this side and that's new, when they've had it for 20 years now. Speech, you're going to see if there's any type of slurred speech. And then time, you just want to get the onset of symptoms. Imaging. So the big one here is CAT scan. You're going to get a non-contrast head CT, and like I said before, that is just to rule out a bleed. CTA, which they use IV dye for, IV contrast, that's to look for carotid stenosis, intracranial atherosclerosis, and large vessel occlusion. MRI, that's going to look at blood vessel abnormalities. Some common complications of stroke are aspiration, so meaning when they're taking food in, any of the contents are sneaking down into their lungs, that can lead to pneumonia. Dysphagia, meaning they're having difficulty swallowing. Urinary tract infection, seizures, depression, deep vein thrombosis, so these are the patients that might not be getting up and active as much, so they're at greater risk for a DVT. And then limb contractures, so that means the patient might have, their hands might become pretty contracted. If I have patients like that, I try to put like a hand towel or a towel in their hand just to prevent it from getting too bad. Video. So this is on Virtua's website. And this is the course of how Virtua will admit a stroke patient.
Every 40 seconds, someone in the U.S. has a stroke. Quick diagnosis and treatment are critical to warding off a stroke's potentially devastating effects. Virtua Memorial Hospital in Mount Holly has an award-winning stroke team in place to care for patients quickly and accurately. And it all starts with a team of paramedics who jump into action when a stroke strikes.
We evaluate our patients to see just exactly what their problem is. When we realize it is a stroke, we call ahead to Memorial, which is our designated stroke center, so they can have the CAT scan ready. It's very important that we notify them ahead of time.
The staff works quickly to assess the patient and determine a plan of action. Assessment includes a CT scan, a neurologist consultation, either in person or via telemedicine, and blood work.
They would need to first diagnose the patient through the CAT scan, and they use the CAT scan in order to evaluate the brain tissue. It can rule out a tumor, it can rule out a bleed. They have to have the CAT scan done first before they can go any further with their treatment.
Once the patient gets here into the ED, we do a stroke assessment. We have consults with neurology, either in-house or consult with specialists on call via telemedicine. It's like having a neurologist directly in the room.
The laboratory is one of the main diagnostic tools that the physician has. We need to check blood to determine if the patient has any abnormal bleeding or clotting issues.
If tests show that the patient is a candidate for a clot-busting drug, it's administered, and the patient is sent to the intensive care unit.
This is the intensive care unit. Patients can expect care by nurses, intensivists, hospitalists, as well as neurologists, and will be monitored very closely by our multidisciplinary team.
As soon as the patient is admitted to the hospital, physical therapy, along with other disciplines, which can include speech and occupational therapy. We work with them at the bedside, and based on their level of functional deficits, we start to progress them first day they're here.
It really takes a team to be able to make things happen. In addition to our direct care providers, we have a whole team that's behind the scenes, really working diligently to make sure that the quality of the care that we provide here at Virtua is at its highest.
Care does not stop at the hospital. Virtua has case managers and social workers who help patients get the care they need after the hospital, including home care, long-term rehabilitation, and outpatient rehabilitation. The extended staff working as a team is a major reason for Virtua Memorial's award-winning stroke care.
So there are actually different hospitals, different types of stroke centers. So there's primary stroke center, which can administer TPA, but they cannot perform the endovascular intervention, meaning they can't do the mechanical thrombectomy. Then there's the comprehensive stroke center, can administer TPA and can perform endovascular intervention. There are dedicated neurointensive care unit beds, and there are 14 comprehensive stroke centers here in New Jersey. So this is the American Heart Association timeline. The key ones are when the patient arrives to the emergency room, you want them to the CAT scan machine within 25 minutes or less, and you want that CAT scan read in less than 45 minutes, and then treatment in less than an hour. So pre-hospital stroke, this is kind of like the timeline in the, you know, the perfect world, this is how things would work. So the onset of symptoms would be less than 4.5 hours. Pre-hospital notification, so meaning EMS or paramedics would then notify the ER with their FAST scale, remember FAST, face, arm, speech time, and let them know of any other type of pertinent information, if they're on any blood thinners, yada yada, if they have any allergies. When EMS arrives, we would like them to actually roll the patient right into the CAT scan, but sometimes that's not feasible. But once the patient arrives into the ER, we want to try to get them to CAT scan as fast as possible. Then obtain lab work, EKG, place 2 IVs and put them on telemetry monitoring. Neurology would then be consulted, and the CAT scan would be resulted within less than 45 minutes, and the decision to give TPA would be made at that point. For in-hospital stroke, so if you have a patient, you go in and assess them at like 4 in the morning, you notice there's a change, you're then going to call rapid response. Rapid response would then make the stroke alert call. A finger stick would be obtained, and CAT scan would be performed within 25 minutes with the CAT scan read in less than 20 minutes after the CAT scan is obtained. Lab work will then be obtained, and neurology will be consulted, and then they'll determine if TPA can be given. Barriers to this timeline. Registration holdups, that just means there are holdups at the registration desk. They might not be able to admit them, might not be able to get the wristband, might not have proper identification. Lack of resources, meaning there might not be enough nurses, not enough staff to help expedite them to CAT scan. Questionable symptoms or presentation, so the doctor might be investigating the differential diagnosis before wanting to administer TPA. CT scan not available, maybe it's weekends, one's broken, you already have some patient in there, you're waiting. Lack of IV access, no orders, delay in obtaining consent for TPA. So strategies to improve time are advanced hospital notification by EMS, rapid triage protocol and stroke team notification, single call activation system. So you could call the operator and say activate a stroke alert, and all the appropriate teams and resources would be notified. CAT scan, neurology, ICU charge nurse, sometimes respiratory, and the lab also. Rapid interpretation of brain imaging, rapid lab testing, including the lab in stroke alerts and stroke education is also key, because getting the labs there, they're like, yeah, okay, let me put this in the pile. But if they kind of understand the urgency with getting these results back, they'll maybe be able to expedite things. Debriefing, so after having a stroke alert and after everything has kind of tapered off, debriefing afterwards is a great tool to kind of learn from mistakes and or praise yourself for the good job that you did. Staff education is key, and I also like the idea of mock stroke drills. We do that at my hospital, mainly just with like trauma alerts, but it kind of gets everybody into the mindset of how things should be run. the aftermath. So if TPA is given, the patient will be admitted to the ICU. They will be placed on telemetry monitoring. When TPA is infusing, you're going to be getting their vitals and do the NIH stroke scale every 15 minutes for 2 hours, then every 30 minutes for 6 hours, and then every hour for 16 hours. When the patient is admitted to the ICU, bedside handoff is very important. I practice this in my everyday nursing, where we give report, and for this it would be the emergency room nurse would come up, the bedside nurse would be present, and you would do a neuro assessment at the bedside together, just to make sure that you're all on the same page with strengths, facials, dysarthria, or whatever. But we do that with both handoff on a regular basis. NIH stroke scale documentation, so you're going to be doing that with your vital signs every 15-30 minutes. MRI and echo, so the patient should be receiving an MRI and an echo during their hospital stay. A 24-hour post-TPA head CT. Physical therapy and occupational consultation, they're very important, especially if the patient is down on the right. They need to learn how to start working with their one side and maybe being able to get that right side stronger. And dysphagia screening within 24 hours after TPA is given. If TPA is not given, they're going to be admitted to just the regular floor, the stroke floor. The nurse is going to present or perform the bedside handoff. They're going to do Q4-hour neuro checks. They're going to be placed on telemetry monitoring. MRI and echo are going to be performed. And then PT-OT consult, and then the dysphagia screening. Performing a dysphagia screening. Has anybody ever done this before? No? You probably do it without being aware of it. So what you're checking for is to see if the patient has any difficulty swallowing. So within Virtua, their policy is that you're going to start with a half a teaspoon of water. They're going to swallow it, and what you're going to be looking for is coughing or clearing of the throat. Next, you're going to do a sip of water by cup or straw, and then you're going to do a teaspoon of applesauce. While they're eating, I would also observe to see if they're pocketing. So meaning, if they have like green beans or something and they open their mouth and they're just sitting on the one side, but they're still eating, like they have no food in their mouth. So you need to make sure that they're not pocketing. If the patient displays no signs of distress or difficulty, they can be advanced to a liquid diet. If the patient is at risk for aspiration, make them NPO, and then a speech and swallow therapist will come up and evaluate them. Patient education. So you want to be educating your patient throughout their stay, not just the day of discharge. So you want to educate them on activation of EMS. So if they're having any signs or symptoms of stroke, call immediately. Need for follow-up after discharge, so going to see their primary care doctor. Medication, so if they're prescribed aspirin, statin, blood pressure medication, you want to make sure they know when to take them, the side effects, if there's any food interactions that they should be aware about. Risk factors for stroke, like we spoke about before, and warning signs of stroke symptoms. Case study. All right, get your phones out. I'm going to try something.
You've got the fastest phone.
All right, so this is a case study, 62-year-old male with AFib on Coumadin. He presented to the emergency room with sudden onset of left-sided weakness 30 minutes prior. His INR was 1.4. His NIH stroke scale was 22. He weighs 90 kilos. His head CT was negative, and door to needle time is 45 minutes. All right, so what you're going to do is this patient, or is Coumadin a contraindication for TPA? So you're going to text, let me know when you're ready, KIM MILLER
I just missed that.
What was it?
Kim Miller.
It's Kim Miller.
Okay.
Oh, that's the.
And then it's you're gonna type that in the to section, Kim Miller 939, and then in the text you're gonna type 3767, and then hit send. Let's see if that works.
67 or like 60.
60, 60,
Okay.
and then 7.
Just making sure.
Did
It's
it work?
Kim Miller 939.
How do you know if it works? Mine said
I
invalid number.
Okay, so here.
It should say like you guys joined.
Mine says invalid number.
Does it?
Yeah.
7,
I was
6.
I
trying.
might have said it like.
Oh wait.
0, what?
No, you have to text.
It's Kim Miller.
No, you have to text
939.
37607.
And then what's the text?
37.
It
No,
is-
it's you
or
text.
37. Text or text
It's
to. Oh, did I say it the opposite?
You
way?
said it the
Yeah.
opposite
So
way.
text. So the number that you're gonna text is 37607. I'm sorry, guys.
It's okay.
607.
And then you're gonna text Kim Miller
93.
939.
Send.
Send. Does it say participating or anything?
Full send.
Oh, so the opposite.
There we go.
Yep.
Yeah.
And then,
Join.
all right.
So it's
So is Coumadin a contraindication?
60.
Oh, here we go.
No, girl, keep going. 60.
7.
7. And go to your text message.
Do you need to be on Wi-Fi?
Now, I'm the oldest person in the room and I had one here.
I know, but I also explained it backwards too.
Yeah.
So give them a little credit.
Where do you go
Mine
under
said-
guest?
Yeah, I just did that. Okay.
Somebody can
So now do the
Kim.
We're too tired. We're not
2
ready
L.
for those jokes.
Oh, I got one answer.
Oh wait, what?
Wait, what?
L? Do we text it to you?
Yeah, text. So
Oh, that's
A
definitely
is
right there.
yes,
39.
B is no. So is Coumadin a contraindication for TPA?
I mean, what was it? I supposed to A or B? What?
A is yes. B is no.
I don't really know. I'm just saying an answer. What's the question?
Yeah, but she just
Is Coumadin a contraindication for TPA? A yes, B no. Goodness, I'm so glad we're doing an activity.
So everybody is pretty much right with this. So the way they will figure out whether they can give TPA if the patient is on Coumadin is look at their lab values. So they're looking for that INR of less than 1.7. So it is not an absolute contraindication where we're going to say no. We're going to look at our lab values first. All right, next one. Now I'm going to ask you to do math.
So bad at math.
So what is the dose of TPA the patient should receive? The patient weighs 90 kilos. Do you remember what the dose of TPA was?
0.9.
Right.
0.9 milligrams per kilogram.
Milligrams per kilogram.
I don't know how to do.
How much does the patient weigh? 90.
That's the lowest one.
Thank you.
Okay. 1 milligrams.
Just keep saying it.
Thanks for announcing.
What?
Text it. Oh, well, you can't text
Oh,
him.
yeah.
But he's right. So
Thanks
everybody's
for
right with
ruining
that.
it.
I mean, I think I'm the only person who answered it.
I answered.
You did? Oh, you did? Okay.
Okay.
What was the answer?
81.
81 what?
Milligrams per kilogram.
All right. When should the dysphagia screening be performed? When the doctor orders it, 24 hours after TPA is given, when the patient is hungry.
Ooh.
That's a hard one.
What was the question again? Sorry.
When should the dysphagia screening be performed?
Ooh, I know.
So when the doctor orders it, 24 hours after TPA is given, or when the patient is hungry.
It just keeps
What can we
going.
eliminate?
The last.
When the patient's hungry.
So if the patient received TPA, you're going to be doing the dysphagia screening 24 hours after TPA is given. If the patient did not receive TPA, you have to do it prior to any PO intake, but we're looking here because the patient is going to be given TPA. Who can perform a dysphagia screening? Nurse, LPN, physician, all the above. All the above. So the last case study was another patient of mine. 71-year-old man admitted to the hospital for a cardiac cath, and this was not the one from yesterday, but there is a common theme here. Patient was intubated and sedated for the procedure. The right groin was accessed for the cath. When the patient was extubated, he had expressive aphasia. Is the patient a TPA candidate? Yes or no?
Oh man.
I forget everything about TPA already.
Wait, can you repeat the thing again?
Yeah.
Okay.
I can go back. No, so it was a gentleman. He went to the cath lab. He was intubated and sedated. His right groin was accessed for the cath, and when they extubated him and woke him up, he had expressive aphasia.
He was at the hospital.
So who answered yes? So why did you answer yes?
Because it happened while they were doing the surgery or the procedure.
But
he didn't come in with that problem.
But what information did I leave out or did I not have? How long was the procedure? So this could have been an 8-hour procedure.
It's true.
And we don't know when it actually occurred. So who answered no? Anybody want to speak up about that? Why'd you answer no?
Oh, I said no because it's like the same thing as if the patient fell asleep, you didn't have the time.
We were working him up to give him TPA. We were waiting on some lab work. We did not meet the time, and we just kind of symptom managed him after that. It was kind of sad waking up and he had expressive aphasia, so he's looking at you like, what happened and why can't I speak to you right now? And then he would start crying. So stroke patients are not easy. But that's it, guys. I really appreciate you listening and participating.
Thank you.
Thank you for the donuts.
You can hit stop now.
Oh yeah.